people that I've seen before, modeling framework, modeling domain, and new faces and new things, so that at some point we all can converge to digital twin, right? So today I work on multi-scale mathematical modeling for the last 10, 15 years. So it's not a digital twin yet. So I'm going to 20 minutes just to explain what we are trying to do. We have been doing with some examples, and just to give a snapshot of what we are trying to do in my research. I'm very happy. I won't be able to give you too much details into how we are doing it, but I'm very happy to have a chat later. Good. So I can skip this slide. I don't need to convince why we are doing what we are doing. So initially, when we start working on multi-scale mathematical modeling, we thought, we like to have some sort of, we have a lot of data, whether I say biopsies, MRI, a lot of patient-specific data, and can we use some of these things to guide, again, personalized treatment? I'm not there yet, but a step before that, can we use that to guide preclinical development as well? Like, can we generate testable hypotheses? Can we say what is the optimum doses of two types of chemotherapy? How chemotherapy can work together with the radiation, etc., etc. That's the type of question. Can we create a lab in a computer where we can test things cheaply and then see, have a dialogue with our collaborators and do this. I know everybody is kind of interested in that kind of motivation. So again, there is a debate, what is the best modeling approach? Is it just simplest 2 ODEs or 1 ODE approach, or having the extreme where you can take, you can include as much details as you want, but what is the best way possible? There is always arguments on either side. You have less measurable parameters coming from clinics, and you need to make sure the parameters are identifiable and so on. At the same time, then are we missing something? So I'm somewhere in between. I really think spatial effects matters, and spatial heterogeneity drive a lot of effects in or efficacy of different treatments and so on. So we try to use a multi-scale mathematical modeling approach where we have intracellular dynamics, where, for example, in my modeling approach, we use cell cycle dynamics. We incorporate cell cycle, intracellular cell cycle within the model, because initially we were motivated to study cell cycle phase-specific chemotherapy. Like if I give 2 chemotherapy drugs, A and B, which acts on different cell cycle phases, how can we combine them in a better way? And also, we like to combine radiation with chemotherapy, and again, they are cell cycle dependent, or is the best way to combine all these things. So we have intracellular dynamics. It need not be cell cycle, it could be anything. We have intracellular heterogeneity, for example. We have oxygen distribution, vector surrogates, the heterogeneity we try to take care of within the domain that we are trying to study. And also, each cancer cells are treated as an individual agent. And we try to put together all these things in a meaningful way. For example, here, the cell cycle dynamics can be, I'm not going to go through all the details of these equations. So cell cycle dynamics can be, it could be just a system of ODEs. Again, it also depends on what kind of questions you are trying to ask, right? If I'm interested in how cyclin B changes over time, then I need to go much more detail into the cell cycle. But if I'm just interested how the changing dynamics influence my treatment outcome, then I don't really need to have a refined intracellular model with it. It could be just a rule-based approach, where if I know the cycling time of a cell is 24 hours, how many percentage of the time it stays in G1 phase, G2 phase, so that I have some changing dynamics that can inform later treatment outcome. Then I have oxygen distribution, which is modeled as a PDE. Then drug distributions, radiation effects, and so on. And then we put all these things together in a meaningful way by using initially cell reports approach using CompuCell 3D. Then we develop our own cellular automata code, and then now we are using Paul's amazing PhysiCell framework as well. Okay, so we show that even if we use multiple framework, the results are qualitatively similar. But again, there is based on each framework that there are differences based on the frameworks. So this is just an example how the model will look like after you implement these models by using intracellular features, oxygen distributions, and how cells evolves over time. So for example, this is where you plant a tumor cell within a normal tissue. The only assumption is the normal cells can grow uncontrollably. Sorry, normal cells can only grow if there's a free space, which means they only grow in the border, and the tumor cells can grow uncontrollably regardless. So they push and pull and just grow. And this is a 3D modeling where you have, so each colors represent the phases of the cell cycle, which cell cycle phase they are in. And here, we can roughly create, there is no flow within our, within this vasculature, the pipes or vessels, and from where oxygen is supplied from the vessels. We can start with the cell and how it grows, and the gradient shows how far they are from. The gradient is the gradient of oxygen distribution. Okay, so this is just to show how this the simulation look like, the framework look like. So you can also create, this is the multiple time snapshot of this multicellular framework, which is good. But now the next question is, once you have this framework, what can we do with this? Right? It's nice pictures, and it's beautiful. I think personally, I'm a bit biased towards it because I made it. So then the next is what can we can we use this to answer some of the questions that we like to answer based on the biology and so on. So to do that, first we need to so we have a tool. The next step is to calibrate the tool for a specific cell line or the data so that we can use the tool to answer questions. So we have shown that, so this is an experiment done by Sarah Brewing, so when she was a PhD student in ICR London. So we wanted to study the combination of radiation therapy with the HIFU, high intensity focused ultrasound. So, so she showed that we can use the experimentally driven data, so the information that comes from the experiments to calibrate. Although the model looks quite complex, you can calibrate the model by selecting some of the data that we obtained from the experiments. And this, for example, this is the fit that we. So again, this is not a prediction. This is calibrating the mathematical modeling framework using the data, in vitro data from the experiments. Then we show later, we can also study combination treatments of radiation and HIFU by initially calibrating the monotherapies. Then we can try to predict what is the combination of these two and different drug doses and so on. Okay, so we have a mathematical modeling framework. Then we have to calibrate this framework to try to answer any questions that we like to answer. And we may need to redo it for the different problems that we want to study as well. So then we try to use this to study multiple problems related to cancer treatments. For example, we studied how this can be used to understand if I want to say optimize different doses of cell cycle phase specific chemotherapy, what is the best way to do it, and what is the role of intracellular heterogeneity in driving some of the drug resistance driven by this intracellular heterogeneity by using computational mathematical models. Good. So the next part, I'm going to the next few slides. So far, this is used to study, optimize some of the things that we want to, like, for example, dosing of chemotherapy drugs. So the next few slides, I'm going to say how can we use mathematical modeling framework to explore some of the less explored, problems in biology. So there are, some things we can't really measure things, but we can use modeling framework to understand it and create hypotheses, which can be possibly tested later experimentally. So we studied something called radiation bystander effects. So radiation bystander effects is where, if two cells are sitting and one cell is radiated, then the other cell kind of shows the effect of radiation, although they are not directly radiated. So this is much more evident at low doses. And there are experiments to measure, not to understand this. For example, they can radiate the cell and try to see what's happening to the nearby cells. They can do a medium transfer experiments where you radiate the cell in the medium, then transfer the medium, culture the new cells, and try to see the effect with the new cells. So for me, I wanted to explore this in the context of radiation therapy. So if you look at the survival fraction or survival curve in radiation, so this is dosage, this is the survival fraction. At low doses, you see some of the cell lines, you say hypersensitivity. You have higher cell kill at the low doses. So it was hypothesized that this may be due to reduced repair. The repair mechanism not really active at the low doses, and that's why more cells are going to dying at the low doses. So together with experimentalists, so I work closely with Professor Gibin Powathil's group from McMaster University, Canada. So we kind of hypothesized that bystander effects are prominent at low doses. So it may also play a role in driving that the hypersensitivity at the low doses. So we use, again, this is completely a computational study. So what we used is, we have assumption the tumor is how it is grown in a host tissue, and then assume that when the cell is radiated, the cells produce some sort of bystander signals, which can be, that assumption is mainly based on medium transfer experiments. When you transfer the medium has something that kind of triggers this radiation effect. So we assume that the radiated cells produce some sort of signals, it's kind of diffuse, and other signals react to it. Very simple modeling hypothesis. And then there's a tumor. These are the blue cells are the cells that are radiated that kind of produce these signals, and they evolve, and then other cells respond to it. And then we have a probabilistic modeling approach, how the cells respond to it, and so on, which I'm skipping at the moment. Then we have shown that if you try to do this experiment by using these assumptions, we can explain this hypersensitivity at low doses as well. So we are not saying this is the only mechanism that play a role at the low doses, but it may be playing a role at low doses. And then later, after we finish this hypothesis testing with computational modeling, then the Commerce group in McMaster did the experiments, biological experiments, and they have shown that this is in fact true. So this is one way of driving hypothesis by computational modeling, and later these hypotheses are tested experimentally in a biological experiment. Okay, so I have 10 minutes. So next, I'm skipping one, each different studies, but I'm trying to say how can we use this kind of mathematical modeling framework to study multiple problems related to cancer. So, so this is hypoxia-activated prodrug. I don't know how many people know hypoxia-activated prodrug. It's like a Trojan horse. So in cancer, hypoxia is always a problem, especially with the radiation therapy, because you need oxygen for the tumors to respond very well with the radiation. That's one reason why radiation is given as a fractional dosage. So hypoxia-activated prodrugs are kind of shown as the next choice in anti-cancer therapy, and they were successful in preclinical studies. How they work? So I think, let me see. So usually, there is a hypoxic tumor. They don't respond very well with this radiation therapy or chemotherapy or some of the therapies. So then the hypoxia-activated prodrug, they go to this hypoxic tumor, they activate with the regions of the hypoxia, and then they reoxygenate the tumor. Then, if you give the next dose of chemotherapy or radiation, it may be much more effective because you have an oxygenated tumor. So that's the concept, and it was successful in preclinical studies. But then, so this is, for example, a cross-section of the tumor where these are the hypoxic tumors. This is after one dose of such hypoxia-activated prodrug. And then, although it was very good, it was not very successful in the clinical trials. So we were reached out by a group in Netherlands, Philippe Lambin groups in Netherlands, to see can we use mathematical modeling approach to explore this and to understand what's really happening. So Sarah, as a part of her PhD, Sarah is in Uppsala now, tried to do our multiscale mathematical modeling framework to see, to understand what's really happening when you treat with hypoxia-activated product, and can we explore what are the mechanisms that are driving this resistance. So we used the data available in the literature to calibrate the mathematical model for the specific cell line and so on. For example, this is the hypoxic area, and this is the proliferating rim, and this is for the experimental data. We try to calibrate the mathematical model so that it kind of work well with the data available in the literature. Then once you calibrate it, we try to use, we try to ask questions. For example, if I have, okay, that's fine. So if I have, say, for example, if I have two tumors, so with same hypoxic fraction, but the spatial distribution of the hypoxia is different. So rather than a big core, I have a large length of hypoxia. What is the role of, how HAP treatment responds to these scenarios? And we also looked at a severely hypoxic tumor, small hypoxic tumor, etc. Different scenarios where you can use computational mathematical modeling to test all these hypotheses. And we have shown that the heterogeneous, the spatial distribution of hypoxia matters in such treatments. So, for example, in these cases, as you can imagine, this tumor responds very well with HAP, better than the tumor with a big hypoxic core. And we also showed that HAP. So HAP is usually given in combination with the radiation therapy, and it works very well in the poorly oxygenated tumor compared to well oxygenated tumor, and so on. So modeling frameworks can ask such questions and try to generate hypotheses or try to explore a less explored area to try to see what's really going on when in the real scenarios. I think I'm running out of time, so I'm skipping all these slides. It's easy to have a few slides on each topic, so I can really skip it. So I'm going to the final, if I can. It's not letting me go. Okay, let me, oops. To the final slide, okay? So initially this, I wrote this slide like 10 years ago. The idea when I wanted to do the multiscale mathematical modeling framework to drive the research that I like to do, can we use patient data, diagnostic data, and treatment protocols to as an input to your mathematical modeling framework to guide some of the treatments? Well, at least to tell if tumor is taken out after surgery, when the patient should come back for the next diagnosis, so that just to see whether the tumor is coming back or not. By looking at the MRI data, you can see the growth, the growth rate of the tumor and so on. I know it's not that easy, but I'm just trying to say, this is what we are doing here. We're trying to see if can we create a digital twin to inform the treatments and so on. So I'm with you, and I'm trying to see what my research can help in driving those things. With that, just want to mention a few papers where we used this multiscale modeling framework to study various cancer-related topics, as well as we also used the framework to study tuberculosis as well, because the framework can be adapted very well. And with that, I'll stop. Thank you very much.
So I've got time for a couple of questions. Yep.
Have you applied it, thinking of the first part,
Yeah.
the bystander model,
Yeah.
Have you applied any of that to SFRT? Because I'm really interested to see what the impact is where you have the spatial fractionation and
Yeah.
the hot and the cold spots, because I don't know of any clear mechanism that explains why that still results in uniform cell death.
I haven't, but what as part of the study, what we tried is, we have a tumor that's growing in a normal tissue, and we tried to see different ways of giving this radiation. For example, if I just target, if I go back to that slide. So, for example, here, if I give the radiation as a gradient, so tumor gets the maximum, but there are normal tissues exposed to this low dose. So that's how you usually give conventional radiation therapy, right? It just revolves around the tumor. And the second case, what we saw is we just give directly full dose to the tumor, but other cells are not exposed to it. And in both cases, we see this bystander effects playing a role, driving that hypersensitivity. And it's not for all the cells. Karma's group did experiments in different cell lines, and they have also seen some of the cell lines also show positive effect as well, like protective effect rather than a destructive effect. And they also did modeling on, for example, they have fish, for example, trout, growing in a completely isolated, I don't know, tub. There you go. I'm trying to find a word for that. And another one, and they radiate one, and they try to study the bystander effects in the next one, which is not at all. The medium is not transferred, nothing, and still they see the bystander effects in the other one. So they say there may be biophotons play a role. So they have few papers published the role of biophotons in where somehow they communicate this. Yeah, we can have a chat. I don't know whether I answered your question correctly, but okay.
Well, I think in the interest of time, we might move on to the next speaker. We can thank Gibin again.
Thank you.